Hello, hello. Hello, hello. This is the life of Dr. Jeff Ask Dr. Jeff. We're gonna wait for him to join. Hi, Evie. Hi, everyone that is joining right now. Today we have a little surprise because normally we do this live on the daytime, but there he is. How are
It
you?
worked. Well, it worked out well.
Yes, that worked. You're
I'm just,
getting faster and
I'm
faster
just,
with
I'm
it.
just, I'm just hitting buttons, and it worked this time.
Ashanti Morciego. Hi, Ashanti, baby
Hey
PR.
there.
Okay, are you there? I think I got cut off for a little bit.
I'm here.
Mhm.
How are you guys doing?
Good. So we have some people, quite of an audience right now. You see,
Wonderful. Yep. Yep. It's
I
the evening
probably
crowd.
it's the evening crowd. Spicy Red 86. She says, "Hi, Dr. Jeff," and all the
Hey
orange
there.
hearts. Baby PR. Hi, Dr. Jeff, and she's
Hey there.
Ashanti. Hi, Ashanti. Taurus. Okay. Well, hi everyone. So, Dr. Jeff, I'm coming back to see you, Dr. Jeff. I'm already at Dr. Jeff doll.
All right.
Beautiful. And Miss Chelinda. Hi, Dr. Jeff. You have a lot
Hey
of
there.
people that love you, doctor.
Oh, that's nice. I appreciate
Um,
that.
I'm still recovering, Dr. Jeff. That's honey cheeks.
Honey cheeks. Nice.
Key Andra, hello, Dr. Jeff, and too
Hey
yellow,
there.
too yellow, too cute. I'm excited. I'll be seeing Dr. Jeff in March, and she has like some hearts.
All right. I'll be there.
March, still it's still 3 months. Spicy Reds is cracking up. So, okay, Dr. Jeff, if you have any question for Dr. Jeff, Marcel Noah, hi, I'm so happy to meeting you next month.
All right. I look forward
Marcel
to it.
Marcel Noah is gonna start the 2026 tuning the body.
Perfect.
um, Doctor, I have some of the questions here from
Okay. Great.
Instagram. If you have any question for Dr. Jeff, take advantage because he's out of the hours of operation, so he
That's
can.
my pleasure. You know I appreciate the love fest. But let's get some questions going.
Yeah, going to do breast lift and 360 with J Plasma. This is from Marcel Noah. She's going, I think, in a month.
Okay.
Oh, Jay Jur, we have some questions here. Why did you become a plastic surgeon?
That's a great question. Am I echoing or do you hear me okay?
I can hear you perfectly.
Okay, great. So why? So the thing is that I wanted to be a surgeon when I was 5 years old, basically. If you go, there's a bio that's on our page. You can take a look at that. It'll tell you a little bit more about me. But I've always wanted to be a surgeon. I'm a very physical, results oriented person, and I also love problem solving. And my background is this is my 26th year in practice, and I did a tremendous amount of reconstructive surgery. I'm a craniofacial surgeon, upper extremity surgeon, so I've done tons and tons of reconstructive cases over the years, and that's really what's put me in the best position to be an excellent aesthetic surgeon, a cosmetic surgeon. In essence, every cosmetic procedure really has a reconstructive background and vice versa. So for me, it's all about the problem solving on the one hand, and on the other hand, it's really about the reward I get from changing people's lives, and for me, that's very exciting and very rewarding. So I've always
Yeah.
been into the science. I've always done research. I've done tons of writing over the years and publishing. So all of this comes together to make it a very rewarding career for me. I was the chairman of the Department of Plastic Surgery for a number of years, and I've run a residency program. So I've done all these things in my field, and now I just focus really on the aesthetic component of the specialty. And for me, this is all rewarding. So thanks so much for that question, and it's nice that you want to learn a little bit more about me. I'm more than happy to share. So yep, send me any questions at all. Nothing's
Eh,
off limits.
thank you, Jay Ewer for that question. Also, Dr. Jeff has how many books you've published already, Doctor?
So I've published 6 textbooks, but my first novel came out last year. and I'm working on
I
my
have it
second.
somewhere over here too. I need it. So yeah, so six books, textbooks, and now a fiction novel
Exactly.
talking about all of you. I'm kidding. No, it's a fiction novel. So okay. So baby PR. Hey, Dr. Jeff, I would like to have a lipo 316, which okay, baby
316.
PR.
That's
That's
a
a new one.
variation. That's a new one. 316. We can do that, but let's just do the 360 and be
Yeah,
done.
360 and PR I guess is for Puerto Rico if I'm not mistaken or not. With a tummy tuck. She wants to have a lipo 360 with a tummy tuck. That's a good choice.
We do that every day. Depending on the situation, we could do a 720 also. So I'm totally
Mhm.
open to doing that. I go around twice.
Yeah.
So I'll tell you, a 360 includes the back, right? So it's the front and the back. And when you do that at the time of a tummy tuck, you have the added benefit of that lower back, which really adds to reducing the waist. So that gives you that's an optimal situation, really. A 360 with a tummy tuck is going to be really better in many cases than just a tummy tuck alone. But for me, every tummy tuck includes liposuction of the flanks, which is the left handle area, and the upper abdomen. So for me, that is included in every tummy tuck, plus repair of the muscle, of course, plication of the erector systosis. But adding the back is only going to give you a better result.
Absolutely. Yeah, I've seen it too. It's a big difference. A good choice. Yeah, what are your thoughts on drainless tummy tucks?
No thoughts. All right, so it's more of a gimmick. All right, and that requires a
Mhm.
number of internal mattress sutures. So if you can imagine what a mattress looks like. Am I echoing
Mhm.
on the other end, or is it I'm getting feedback, but you don't hear that?
No.
Okay, perfect. So if you think of a mattress, all right, that has all these pleats in the middle of it, right? That's what a drainless tummy tuck is. So underneath the flap, you're actually using sutures to pull it down, so it's just stuck against the abdominal wall.
Mm.
When you do that, you could end up with irregularities and asymmetries because of those sutures. So
Oh.
I never do that. Instead, I use two drains every time. They don't result in any additional scarring. They don't result in any additional discomfort. And we pull them out at 14 days and done. So, it's just people will advertise, it's like awake liposuction.
Mm-hmm,
Bad
mm-hmm.
idea.
Exactly.
I'll never do that operation.
Yeah,
These are gimmicks. All right.
exactly.
Like, why would you want to be awake? It's very
Mm.
painful. It's very uncomfortable, and the surgeon can't be as aggressive. Okay,
Yes.
so you can't do as good of a job, and you've
Mm.
paid. Sometimes they pay even more than we
Yeah.
may charge.
Mm-hmm.
Doesn't make sense to me. I'd rather have
Yeah.
somebody asleep. If it were me or family,
Mm-hmm.
I'd be asleep. All
Yeah.
right, there's no question. It's totally
Absolutely.
safe. We
Mm-hmm.
have phenomenal anesthesia team.
Yeah.
It's completely safe. You're completely asleep. You never wake up prematurely, but you do always wake up at the end of the procedure. There's no reason to not do that. It's like today.
Exactly.
Somebody today asked me about, the lunchtime lift, meaning, like the lift with sutures that lift the cheeks, and they do it. It's a quick, like, 20-minute thing. And my response is that they call it the lunchtime lift because the
The
result doesn't last
lunchtime.
until dinner time, right? So the result doesn't last until dinner time. It's not a good operation, all right? So, but we're not talking about that right now. But that's another kind of gimmicky, quick, like the short incision or the minimal incision
Yeah.
with no scar. These are gimmicks, and people pay money and then they realize that they've wasted their money.
Yes.
So I don't think that's ethical either. So I don't do those
Mm-hmm.
procedures, and the drainless, it's a gimmick. There's no advantage to that.
I actually have never heard about the drainless tummy tuck.
That's how they do it. They just tack down the abdominal wall with rows of stitches, and
Mm.
then you don't need a drain because there's no dead
Oh.
space. There's no
Oh.
possibility of forming a collection because you've collapsed everything. But why do we keep the drain for 2 weeks? Number one is to prevent, a collection from occurring. But number two is that even if you're not putting out any fluid, the second reason I do that is because of that suction. Okay, so that suction allows
Mm-hmm.
the flap to stick down to the abdominal wall.
Correct.
So
Natural. Mm-hmm.
people say, "Oh, I'm not producing a lot of fluid. It's a week. Can we just take them out now?" And the answer is, "Oh, that's great." No. All right.
Mm-hmm.
So
Mm-hmm.
I'll cheat with like one day. But the reason I keep it the full 2 weeks is because I want to achieve that flap laying down, and that little bit of suction keeps it there. So instead of putting all these additional stitches, causing more scarring, potential asymmetries, potential
Okay.
irregularities, instead of doing that,
Mm-hmm.
I use the suction from the drains,
Exactly.
and that accomplishes the same thing. And so what? You've got two drains in place. It's just not a big deal. It's really
It's
not.
not. No, it's how many hours? This is from It's Mexio. How many hours does it take in the surgery room to make a tummy tuck in a BBL?
Well, that's a great question. All right.
Hmm.
So for me, it takes about 3.5 hours. Okay.
Hmm.
But patients ask me this all the time. And my answer is about 3.5 hours for me. For you, it's like 5 minutes. Right.
Exactly.
Boom, you're out, you're done. And then you
Hmm.
get to the recovery room and you're like, oh, when are you going to start? And the answer is that we've already finished. All right. So, but about 3.5 hours.
For Honey Cheeks, he is amazing. This is my second round, and he knew exactly what I wanted without having to tell him. Every problem area is totally gone, and it's
Oh,
only
that's
been
great.
2 days.
Oh, that's
Book
great.
him, sees he's the truth.
Oh, that's great.
Oh,
That
that's
was
so
just way sweet.
nice.
I appreciate that, and I do have an idea. In general, 'cause I've been doing this, a lot, and people want to show me photos before surgery or day before, week before. That's fine too, okay? Because in my mind, I have a picture of my goal for you, but showing me a picture is perfectly fine. So that if it makes you feel more comfortable, why not, right? But I have a
Exactly.
pretty good idea of what you're looking for. And everybody comes in and they say, oh, I want this like tiny, tiny waist. And I tell them, like, oh, yeah, like a Ritz cracker, right? So I get it. I get it. That's my whole concept of reversing the curve, right? We're bringing in the
Hmm.
waist, we're filling out the hips, and we're giving you a more feminized shape, feminized figure. That's the goal. Nobody comes in and says, I want my hips flatter and I want my waist fuller, right? Let me think. Yeah, nobody comes in and asks that, right? So I get it. But if you want to show me a picture, that's fine. But in most cases, I really spend a lot of time analyzing you while I'm talking with you. I've already got the plan. So I appreciate your feedback.
Doctor, this is a very interesting question.
Okay.
You Donna hate the most.
Say it again.
This is from Juju, the one you all hate the most.
What do I hate the most?
No, that's the her the name of the person.
Oh,
So
oh
she's
wow,
asking,
that's a
or he's
mouthful.
asking, are you or Dr. Pittman better for plus size woman?
Well, I'm better. Pittman sucks. Now, now I'm joking. I love Pittman. He's a great guy. He's very talented. Still, I'm a little bit biased, but yeah, many of my patients have lost between 100 and 300 pounds. We had somebody actually, and I think she may even be one of our posts, maybe it was a month ago or so, or 2 months, who had lost, I think it was 400 pounds. Do you remember?
Mm-hmm.
So no, so I've been doing either post-bariatric, meaning patients who have had a sleeve, a gastric bypass. So we do these patients all the time, and many of these patients have lost 100, 150, 200 pounds, and that affects the entire body in many ways, right? But no, Pittman's a good guy too. I just, I just, I just think I'm better, right? You know.
Great answer,
But the
doctor.
bottom line is that it affects the body significantly when we're
Yeah,
doing surgery of the breasts, the arms, the belly. There are also consequences to significant weight loss. First off, you're going to be much healthier. All right. So that's a great consequence. Patients with diabetes and high blood pressure, these things are significantly improved and sometimes they're eliminated completely by losing a significant amount of weight. Okay.
mm,
But one of the things that also happens with the bariatric patient population is we also have a situation where we're not able to absorb nutrients quite as well. All right, so the digestive system has been altered by manipulating the stomach, by manipulating a number of things
hmm,
that allow us to lose weight. The reason you're losing weight is because clearly you're not absorbing everything. And also, the GLP, all these different, new medications, they're fantastic. Okay, they're wonderful, but there are also consequences. So they affect perhaps like transit time. Okay, so things sit in the stomach longer. So your body, your mind thinks that you're full and therefore you eat less. And that helps you lose
okay,
weight. And that's great. But there are consequences. Okay, so patients who have lost 100 or 200 pounds, the skin is now much thinner and it's often like paper. Not as
yeah,
much of a problem with the belly, perhaps, but with the breast. Okay, so now patients I want to be huge, and we'll go with fuller breasts. The lift itself gives you more fullness, and then we use an implant in most cases.
exactly.
But you have to keep in mind, I don't want to belabor the point, but you have to keep in mind that when you're going very large, the breast tissue still needs to support those implants and maintain the
Mm,
position. So
yeah.
a year later, patients may come back, oh, my breast is coming down again. Say, right. So we talked about this before we did the
The
surgery.
quality of the skin.
Is completely changed. It's just
Hmm.
not the same. Just like a woman who's had, one child. I had
And
somebody here who's had six
yeah.
children. The quality of the abdominal wall is completely different. That's just the nature of it.
Hmm.
And I'll say
Exactly.
one
And
more
in
thing.
that case, that when they have breast lift, and let's say the quality of the skin doesn't support, so like in a couple of years or in a year, probably they feel like it's true. I mean, it's not as perky as at the beginning. They can
Right.
just do another round, right?
Of course. Oh, of course. You could just redo that. You could just tighten that, of course.
Hmm.
But the concern is that sometimes patients don't realize that. Patients always forget where they started.
Well,
And
in
that's
that
okay.
case,
It's normal.
yeah, in that case, they do you think it would be better to go with a smaller implant, or it doesn't matter?
No, I think it does matter. So in some
Hmm.
cases, depending on the skin quality, and
Hmm.
this is something that's been talked about in our field
Hmm.
for decades.
Hmm.
This is not new. Okay,
Uh-huh. Yeah.
this is not new. And but some of the
Interesting.
techniques for losing weight are new,
Hmm.
but the concept of we call it massive weight loss, that's not new, and the consequences of that are well understood, and the
Hmm.
effect they have on the quality of skin can be dramatic. So the difference between working with a patient who's got wonderful skin tone, healthy skin, no weight loss, she's always been thin and that's not an issue. That skin quality is going to be very different than the person who's lost 200 pounds and the breasts come in and they look shriveled. Basically, the skin looks, you can look at the skin and it kind of has like a crepe paper, if you know what that is, like that kind of wrinkly
Hmm.
appearance to it. And it's just, and if you pick it up, you could pinch it, and it's like tissue paper.
Hmm.
That's not going to support the implant as well as
Because it has less collagen or something.
absolutely the dermis.
Hmm.
All the strength in the skin comes from the dermal layer. Okay, so the
Hmm.
skin that you look at every day, that's your epidermal layer. Underneath that is your dermal layer. And when we
Ah, okay.
suture, what we're grabbing is the derm. When we're closing skin, that sort of thing. All the strength. This is a question for like residents. All the skin, sorry, all the strength is in the dermal layer. Okay.
Correct.
When we're fixing the muscle for a tummy tuck, that's different. We're now down a couple layers. All of the strength there comes from what we call the fascia, which is the layer
Hmm.
above the muscle. The muscle itself, ironically, barely can hold a stitch. It has no good strength at all. So you never grab the muscle. You grab
Oh,
the
wow.
fascia on top of the muscle. So
Oh,
as a
wow.
surgeon, yeah, so people don't know that. It's, oh, you've incredible, even Schwarzenegger, his muscle would be terrible, well, he's older now, but in his
Oh,
prime, his muscle would be terrible. It's just the nature of it. The muscle,
exactly.
contracts and gives you bulk and strength, and it basically is attached to the tendons, which are attached to the bones. That's how we move, right?
Hmm.
So that's how the body works. But the muscle wasn't made for strength itself. It was made for generating strength, not for itself being strong. The tissue on top of it is what we grab, and that's what we use to
Yeah.
tighten the muscle. Just like the dermis, getting back to your point, I'm digressing, but it's fun
Yeah.
to it's fun to talk about this stuff. We talk about this stuff all day. So the dermis is what we grab. So now, getting back to your point, when you've lost a lot of weight, when you've had implants for many years, a number of different things can basically result in dermal atrophy. So you've got thinning of the dermis. So now when you go to suture that, you no longer have that strength that you once
Okay.
had. All right. So that's the short answer. All right.
Okay.
I can give you the long answer. That's the short answer in
let's
my mind.
let's stay
All
with the
right.
short answer.
That's the short answer. But
We can get the
that's a
longer
great
answer,
question
but we can get the longer answer upon
from one of my
request.
books or upon request. But this is really interesting, and it's important for patients to understand. And before surgery, I spend a lot of time. So this patient's name has something to do with the worst something.
Oh, yeah,
So,
yeah.
so what I
She's actually adding that my BMI is 40.
okay, so that's somebody that we definitely want to bring the weight down below
Yeah.
38 to do these
Yeah.
procedures. Okay,
Yeah.
but I thought that she was asking me, and I want to go off on another tangent. But I thought she was asking me. Sometimes you ask me, "What's my favorite procedure?" Okay, but I don't think you've ever asked me like, "What is my least favorite procedure?" And there are some things that I don't love doing.
Hmm.
Okay, and it's not because they're challenging. It's not because the patients don't want them. It's because I know from doing so many procedures over so many years that the result is just not going to be what the patient or I want. So what is that
Mhm.
procedure? Okay, and there may be several, but one procedure in particular, and it goes back to what we just talked about, is the patient who comes in with very large breast implants and drooping breasts. And she now wants to remove the implants and then lift the breast. And we've had, we don't see this very often, but I've had a number of these over the years. I've had one recently, and they want to remove very large implants. And my conversation is something to the effect of, what you're going to have when you remove this implant is very little breast tissue. You're going to be pretty flat, and you're going to have basically an empty bag of skin.
Mhm.
Okay, because many patients have gotten implants because they have no breast tissue. Some patients have good breast tissue, they just want to be bigger, and everybody's different, right?
Yeah,
But many
exactly.
patients, I call them the emergency augs. Some patients just have no breast tissue, and then
Mm.
they look wonderful after an augmentation. But keep in mind that now you have that implant in place for a number of years, and it's stretched that skin. All right, it's
Yes.
caused dermal atrophy, all right, by pressure on the skin. It's caused a potentially muscular atrophy by pressure on the muscle, but you still look good, right? Because you have the implant in place. Maybe you need a lift down the road, right? Because over the course of time, the breast is going to descend. The implant will hang lower. That's okay. We can do a lift without touching the implant, leave it in place, and do a nice lift.
Mm.
Perfect. But when you take out that large breast implant, you're going to have an
Mhm.
empty bag of
Mhm.
skin that's flat on the chest. And now the
Mhm.
patient wants that lifted. So my typical conversation is, I'll tell you what, why don't we perhaps go to a smaller implant that
Correct.
you still have some fullness,
Exactly.
you look very feminine, you look perky, we can raise the breast, you look younger, and have a smaller, perky breast. And sometimes the patients will say yes, that's a great idea, and sometimes they will say no. All right.
That's a
And
bad
when they
idea.
say no, I remind them that you're going to be flat, the nipples will often be higher, okay, because now we're taking all of that, and you can't see where I'm at, but all that skin is being bunched up, okay, so it's pleated, and you see where my finger is. So I only have two hands here. You see where my finger is, and now that crease is all the way up here, and we have to cover that by putting the nipple in that location. Because if you put the nipple lower, you'll then have a scar, a vertical incision above the nipple. So there's a lot of geometry involved in these procedures, and patients
Mhm.
may not always understand
Realize it.
that.
Yeah.
Right, and patients are intelligent. Some of my patients are doctors, some are lawyers, some are accountants, some are, doesn't really matter what they are. They're stay-at-home moms who are smarter than everyone, right, and work harder than everybody. So I get that. I get that. But the bottom line is what patients don't really understand is that they have to think this through, because I'm telling them very specifically that this is probably not going to be the result that I want. All right.
Exactly.
And sometimes they say, nope, I just want them out. I want it lifted. And so that is probably my least favorite procedure
Oh wow.
of
No,
all
I
the
can
ones that I
understand
do.
why.
Yeah.
Um, yeah. Let me. I have a lot of questions here.
Oh,
Do
sure.
you
Let's go for it.
okay? Do you recommend staging your surgeries?
Sometimes.
Doing your tummy tuck first and 6 months doing your BBL. Any benefits with doing stages or even at once? Like I guess
Sometimes.
pros and cons.
So I do combinations all the time. All right. If there are no
Yes.
medical issues, if the BMI is below 38, if there are no other reasons, no medical problems, no compromising situations, I'll go ahead with a combination procedure.
Mm-hmm.
But there are many patients who want to separate out procedures, and that's fine too. It's all about your comfort level.
Correct.
I can go either way. But if somebody's coming in and the BMI is 43 and they're diabetic and they're hypertensive, we're probably not going. In fact, we're not going to combine procedures. I've had people come in and they're ready to go. They see me, days in advance before the procedure. They're coming in for their combination, and they're leaving that day, understanding that when we do surgery the next day or next week, that they're going to have one procedure because I've decided, based on their hemoglobin, their BMI, their medical conditions, or their combination of what we call comorbidities, that they're not a good candidate for a combination procedure. But if you were to separate them, for me, I would do the BBL potentially first because that's when we're harvesting the fat. So let's use it, okay? Or you could just do a tummy tuck and the front, the flanks, etc. But don't do a 360 because that's my extra fat reserve, reserve of fat
If you
tissue
want to do the
that I'm
BBL
going to
after.
use.
Mm,
Exactly. So then you can do that. But there are different things. So send photos, send questions, come in and see
yeah.
me. We can answer all these things, but sometimes we stage things. Sometimes, occasionally, we'll do even three procedures at once. The two that you mentioned, and maybe an arm lift. Okay, I'll never do it. I'll never do a tummy tuck and a thigh lift at the same time because the incisions are just too close.
Mm.
That will result in compromise of the skin, and there's just no reason to do that. So some things just should not be done together. Okay, but
Mhm.
many other things can be. The question is, are you a good candidate for that? So we'll look at all the,
Mhm.
we'll look at your medical history, we'll look at a number of things and make that determination. But we can do it either way.
So if you want a consultation with Dr. Jeff, just send us a DM with your name and your phone number, the word Dr. Jeff, and we're gonna get you in contact with Dr. Jeff for a consultation so he can answer all your questions too.
Absolutely.
Um, Kim Briste, can you take care of a hernia with a tummy tuck, or should it be done beforehand?
Well, what kind of hernia? If it's an umbilical hernia, the answer is yes.
Mhm.
Okay, if it's a groin hernia, that's going to be done by the general surgeon, right? If it's a
Mm.
big, huge ventral hernia, that might need a CAT scan first and may need to be addressed by the general surgeon. If it's a larger hernia, of the umbilicus, of the belly button, I usually repair those when I repair the muscle. So I do that at the same time. But if it's
Okay.
a very large hernia, and I don't know if she mentioned the tummy tuck, but if you're doing, say, liposuction alone, we're going to avoid that area because we don't want to
Mhm.
damage it. We don't want to injure it with the cannula while we're doing liposuction, right? So,
Correct.
so there are a number of things we take into consideration, but there are some cases where we want more information from a CT
Yeah.
scan or CAT scan, and there are some cases where we do want the general surgeon to do it first, and then we do our tummy tuck afterwards. And then there are cases where we just do it at the same. I do the repairs myself at the same time.
Okay. And it's Mexio. The BBL includes the back lipo.
Every time,
Mhm.
every time. That's the 360. That's with the BBL. But
Mhm.
before the next patient asks, can you also do the arms? Are the arms included? So you can add anything you want. We had the arms, we had the inner thighs, we had the chin. We could add all those things, anything
Mhm.
you want. But what's included with the
Correct.
BBL is the full front, right? The abdomen, the flanks, and the full
Mhm.
back. All right, so we can add any of those things. For me, just to belabor the point, with a tummy tuck, what's always included are the flanks and the upper abdomen.
Correct.
Mhm.
Okay. Hi, everyone that is joining. We're here with Dr. Jeff. Yes, I don't want to be awake. This is regarding
Yes,
the.
only
Oh.
one of us needs to be awake, and
Exactly.
it's not the patient.
Um, Hello, I'm scheduled. This is from Healing Inc. I'm scheduled with Dr. Jeff on January 8th.
Okay, I will be there.
That's Dainelli's birthday. Do you recommend
Exactly.
lymphatic massages? And this is from um, Juju, the one you all hate the most.
Fair enough. Yeah, that's a great question. I absolutely recommend lymphatic massages, but you've got to have qualified people doing this. So a number of years ago,
Mhm.
like 5 years ago or 6 years ago, I had somebody who left town and had their massage person do them, and we ended up with an issue with the abdominal flap because for
Mm.
whatever reason they decided to do the massage on the abdominal flap. That can be a disaster. Okay, so our
Mhm.
team is phenomenal, but with a tummy tuck, you can do the flanks. You're not going to cause any problems, but nobody touches
The
the abdominal
massage.
wall.
Mhm.
Exactly. With a BBL, absolutely, we do the front, we do the back, we do all
Mhm.
of it, and that speeds the recovery process, right? So makes the swelling and the edema that all resolve more quickly, and that helps us get to the final result. So I absolutely recommend that for sure.
Juju, the one I'm scheduled for March 2026, and she's doing like a little piece
Well, I like the
hand.
peace sign. All right,
Healing Inc. just got my medical clearance, and she's happy.
all right, good.
Let's see. De Inés Heredia, she's asking cuáles son los planes de financiamiento, what is the financial plans. Dayanis, envíame un mensaje con tu nombre y tu número de teléfono para ayudarte con eso. Tenemos muchas opciones. Marcel Noah, how long for breast lift 360 with J Plasma, doctor? How long for breast lift 360 with J Plasma?
About 3 hours again for me. For you, about
Oh,
5 minutes.
exactly. Mrs. Int 83, do you try different implants during the surgery, or do you know before exactly what to use?
We usually make the decision. We always make the decision with the patient in advance, so we know exactly what we're doing. In the case where sometimes we remove saline implants, we can't be sure exactly what they have.
Mm.
Okay. Sometimes we have ruptured implants, so then we don't know what they have at all. So I can
Mm-hmm.
also use sizers during the procedure to make the best decision for what size to use.
Mm-hmm. Mm-hmm. And Healing Inc., do you recommend vitamin IV drips 3 weeks before surgery?
I have no problem with vitamin drips, but
Mm-hmm.
I would avoid the some of the crazy supplements, right? Because
Yeah.
some of those cause bleeding, some of those, so you want to avoid that stuff. But yeah, vitamin, I have no problem with vitamin drips.
Doctor, how long before surgery, like people has to stop the all the shots for losing weight, like Ozempic, Manjaro, all that stuff? How long before?
Ideally a month before.
A month before. Okay.
Mhm.
What about PCOS, trying to lose weight for the surgery?
So that could be challenging. It's polycystic ovary. All right. So that's
Mm-hmm.
what that is. And we have a number of patients who have had that over the years. But, I think, so it's difficult losing weight, right? I mean, there are different modalities. I would speak with a nutritionist, speak with your PCP, your doctor there. It may require, one of these, GLPs, but only in, those are really recommended for people who have non-insulin dependent diabetes.
Mm-hmm.
So it's a challenge, but send us a photo, send us your height and weight and things like that, and we can see where you are exactly and
And
what you
your
need to
phone
do,
number.
and that too,
Jay,
so we can contact you.
she has very good questions. Why did you
Okay.
choose smart plastic surgery to
Why?
practice as a
It,
practice?
it it was definitely the smart decision. All right, so I really think that it's probably the best. I think it's one of the best practices in the country, and I've been in some of the best places in the country. I've trained at three Ivy League universities. I was on the staff at Brown. I was a chairman in Boston. I've been in Chicago, one of the busiest practices in the Midwest that I developed there. So I know what it takes. I've had my own operating facilities, my own buildings. So I know what it takes to build a strong practice. It takes good people. It takes great patients, but the good people attract the great patients, right? And basically, we have a great anesthesia team. We have a great management team. We have wonderful people who make everything happen for us in the operating room and out of the operating room. We have a great nursing team. We have a wonderful nurse practitioner. We probably have, probably the best, marketing media team. And you're looking at her. Lily's the director, and she won't tell you this herself, but she actually won an Emmy Award, an actual Emmy Award that you see on TV, an actual Emmy Award. So she's won one, which is phenomenal. Like I've written a bunch of books, but I've never won an Emmy Award. All right, so that is our media director, and she's not great just because she does, great video and all of that stuff. She's great because she spends a ton of time speaking with our patients. So
Absolutely.
it's not just the posts that are
They
really.
know.
She knows this. She's
They know.
oh, they know, right?
Yeah.
They know, right? Of course, a little immodesty, but that's okay. So that's why I chose smart, because I think from everywhere in, from the top to the bottom, everyone in between, we have a phenomenal team, and I like everybody there. I mean, I work well. I think maybe they don't like me, but I think I work well with everybody there,
We love
and
you,
I really
doctor.
and I really enjoy it. So I really think it's not only smart. I think it's the smartest place to be. I really do.
Awesome. Great. Vere 94, yo quiero un tummy talk con Dr. Jeff. She says, I want a tummy talk with Dr. Jeff, and she puts like a little almost crying face.
Almost crying, tears of joy. All right, so come on down, come on down. I'd love to take care of you.
Very, and then Jay, when should I start my supplement recommended for the surgery, and how long after should I continue?
Okay, so we say some of these maybe a week before, 2 weeks before. Some patients may have iron, so everybody's different, and we tailor these
Mm.
regimens to our patients specifically. Some things are for everybody, but somebody asked before about IV vitamin drips. That may not be needed by everybody. Some people may need iron supplementation, that sort of thing. So the paperwork that we'll give you will tell you exactly what's needed in your specific case, what clearances might be necessary, what things need to be stopped in advance, and what things need to be taken. For instance, if you're taking blood pressure medication, we want you to take it actually the day of surgery with a sip of water in the morning. So we don't want you to just stop taking everything.
Oh,
Some
okay.
things are actually necessary, insulin, things
Exactly.
like that. Typically, in my career, I've had patients take one half of the dose but don't listen to me. We're going to put a plan together with your PCP, okay? But so we don't just abandon all medications because you're having surgery. We just pay a little
Mhm.
more attention to what you're taking tailor what you actually need to get through the surgery and after the surgery, and then we go from there. So again, everything's a really tailored approach. But if you tell us who you are, what we're planning to do, and then we can go into your chart, into your record, and the paperwork will already be there, but you may not have received it yet if it's a little too far in advance. That's a great question.
Wendy Susini says, best doctor. Hi,
Oh,
Wendy.
hey there, how are you doing? It's actually Wendis, technically, right?
Yes, our Wendy, yes. Um, okay, let me check if we have more questions over here. Pretty Brown Slim, hey doctor, and she puts like a
Oh, cool.
strong arm.
Nice.
And this is oh, Marcel Noah, this is happening to me, doctor. I have implants, but my breast is down. It's a lot of skin around.
Right. Sure.
And she's already booked with you.
For a
Me
lift,
too. Me too.
for a
Oh, there's
mastopexy.
because there's like comments that they were like, Luisa Isadora 143. Me too. In this case, I have exchange.
Sure.
Hmm.
So there are a few reasons why we may exchange. All right. Also, we treat patients who've had implants for a number of years may or may not have capsular contracture, so we have to address that at the same time. We may do an exchange because some patients want to be larger, some want to be smaller.
Hmm.
Okay.
Exactly.
So we could do that at the time of a lift procedure as well.
Hmm. Dilma Hercules. Doc, what are the things you look at to choose the right size for breast augmentation?
So that's a great question. Okay. First, where are you right now, right? Where are we starting? Where do you want to end up? Okay. And you could tell me I want to be 2 cup sizes fuller. You could show me a photo, but I have a pretty good idea based on that. Also in the mirror, with you, sitting in front of me and a mirror behind me, I kind of show you a few things that I would do, to enhance the size and kind of give you an idea beforehand of where you might end up. So there are a number of ways in which I decide. Again, going back to something we talked about 15 minutes ago, is the quality of the skin. All right. So depending on how, what the quality looks like, that's also going to play a role. Somebody may come in, have very thin skin, they've lost 150 pounds, and they want to have, 700 cc implants. We're probably not going to do that. Okay. So then we start negotiating. All right.
Hmm.
I start at like 350, they come down to 650, I go to 450, and we end up somewhere in the middle. But it has to be a place where we're both comfortable. But ultimately, if I'm not comfortable, I'm just not going to do the surgery at all. So I want you to be happy. But if I feel that you're not going to be happy with this compromise, then
Exactly.
I might not be the right surgeon, and maybe we have to go to one of my colleagues. But usually that doesn't happen. Usually we find, some compromise because I'm giving you the same advice that I would give, a relative of mine or anybody that I care about. And I've been doing this for a long time. So if I tell you that's too big, you probably want to listen to my advice. If I tell you we could probably go up a little more than that, if you really, to get where you want to be. Sometimes patients come in and they just throw a number out, and sometimes that doesn't correlate with how full they want to be. So they throw a number and a photo out, and then we go from there. But otherwise, it's really a direct conversation. It's a team effort, right? So it's a direct conversation to decide where you're going to end up. And usually we hit it on the head, so I think in most cases, you know,
So, doctor, I think what we have, thank you for your generosity because we have almost um, a little bit more than 40 minutes, I guess, with
no
every.
problem. These are,
I-
these are evening hours. Not a problem.
um, so I have some other questions here. I'm gonna take a couple of more. I
Sure,
don't know how much are you good with time,
sure. We'll go for a
but
couple more.
mhm. Dr. Jeff, see you on April 1st. Question: what is
All right.
Cell Saver?
What is what?
Cell Saver.
Oh, what is a cell saver? Oh, that's a great question.
Mhm.
So cell saver is a device that's been used for decades now. It's completely safe, and it does what the name says. It saves cells. Okay. So in a patient in whom we might not have quite the high enough hemoglobin blood count, and we suspect we might lose a little bit of blood if we're doing a combination procedure, or if we're doing, aggressive liposuction with a BBL procedure, we might lose a little bit of blood. So what the cell saver does is we suction the blood. It goes into a sterile chamber. It's a piece of equipment. It goes into a sterile chamber. It's filtered. It's washed. It's put into an IV bag. That is then given back to the patient. Okay, so
Mhm.
there's a zero chance of any contamination because it's only your blood. There's nobody else there. It's one device, one patient. and it goes right back to the patient.
Yeah.
So sometimes we say we may want a patient in advance, to go ahead and book the case with a cell saver. Sometimes we may, make a decision intraoperatively and go from there. But that's a great question. It's nothing to be afraid of. It's just an extra precaution that we take. That's
Correct.
smart because it's a very smart thing to do in some cases. And so if we need it, we're going to use it.
Okay, I want to shoot you some questions. So, like, just like a quick
Oh, quick
question.
one.
And I'll let you go. Doctor, do you do small tummy tucks?
Mini tummy tucks? Yes. We do small tummy tucks for small tummies. Right, so
Yeah.
keep in mind that the skin, only half of the skin between the belly button and the incision, you're really only addressing about half of that skin. Okay?
Hmm.
Because if you addressed all of it, then the belly button would be living at the incision.
Hmm.
Okay? So think about that for a second. So if you've got skin hanging over over the belly button, you're not a candidate. If you have too much fullness that requires repair of the muscle, you're not a candidate. So it's very small. Probably 5% of our patients are good candidates for that. But you can send us a picture. I can give you my advice. But the short answer is yes, we do those.
Yes. Just Andrea, do you do tummy tuck, and how big is the scar? What is the difference from a regular tummy tuck?
You said I should just say yes, right? So
Yes.
that's a tough one to just say yes, right? So the
Yes.
incision is, let's see, my fingers are out here. Right. So basically, if I made the incision just like this big, right, how would I remove the skin that's out here, trying to be in the camera, if the
Hmm.
incision is just this big, right? So
Hmm.
typically it goes from hip to hip.
Hip to.
Okay.
Hmm.
If somebody has a lot of additional skin that wants to go posteriorly, then they're going to require an extended tummy tuck.
Yeah.
And, it's nothing to be afraid of. It's just, we're just extending the incision to do the best job of removing all of that skin.
Okay. Um, okay. Also, doctor, I have other questions right here. So, how many weeks before surgery I should stop smoking?
That's a
Uh,
great question.
he says I'm struggling.
Yeah. Well, my preference is 4 weeks. I can live with 3 weeks. Depends on the
Hmm.
procedure.
Hmm.
Not
Hmm.
as critical for breast augmentation, but
Hmm.
for breast lift, we could lose a nipple. All right. Not
Hmm.
as critical for liposuction. We're removing the fatty tissue, but if we're doing liposuction with a tummy tuck, we could lose, that flap of tissue. We could lose the belly button. So, more critical for BBL because we can lose the fat that we're transferring. So, we also test for nicotine. So if you're nicotine positive, we're not going to do the surgery.
Correct.
But you could be negative and then start smoking the next day. That would be a
Hmm.
disaster. Okay, so
Yeah.
preferably a minimum of 3 weeks before and 3 weeks after. The good thing is I've had so many patients over the years who do that and then they just quit completely. So it's a great
Mm,
motivation for
absolutely.
quitting. Yeah, for quitting smoking.
Because
But
not
that's
even nicotine patches, they can. It doesn't.
the
It's not
nicotine
an
patch
option
is
for surgery.
right. So nicotine patch is a disaster. Okay, the only thing the nicotine patch does is it prevents the nicotine and the smoke, the carcinogens, from going into your lungs. But you're
Hmm.
getting all of the nicotine that will destroy your tissue after surgery through the patch. The patch just absorbs it through the skin, so it goes right into the bloodstream, and it goes to the blood vessels that are going to constrict, shrink down, and prevent my tissue from getting oxygen. Right?
Yeah.
That's all blood does. It delivers oxygen and
Yeah.
nutrients, and basically nicotine patch, disaster.
Yeah.
Vaping with nicotine, disaster.
Hmm.
Smoking cigarettes,
This.
disaster. All right.
Yeah, it is a disaster. I've seen it. Like the scar heals horrible.
We get
Uh,
horrible scars. We get breakdown of
mhm.
this. It's just, it's a disaster. So don't do it.
Marcel Noah says, thank you for the answer. And just Andrea,
Plus,
even if it's a mini tummy tuck, it's hip to hip.
well, it depends. It might be a little bit less in that case, right? If it's really mini, then sometimes the mini is just skin between where am I? Between my fingers, so the incision will be like between my thumbs. All right. So no. So that could be a shorter incision, but very often, if they have skin that's just hanging down all the way across, I'm going to follow that skin, right? So
Correct.
I'm going to go after that extra skin. So you tell me where you want me to stop.
Exactly.
All right. And I had a
So,
patient recently who said,
mhm.
you know there isn't going to be a dog here, is there? And it was as if it's like, oh my God, it's not going to be, cancer. Like a dog ear is just extra skin. If the incision's too short, then you're
Yeah.
going to have that fullness and you're going to have a dog ear. It just represents skin that wasn't removed fully. That's all it is. Right? It's
Mhm.
not a disease. It's not a death sentence. It's just skin. All right. And sometimes surgeons make the incisions perhaps too short, or sometimes patients have just so much skin that goes to the back all the way,
Mhm.
like a Michelin type of, skin excess that you just can't trace all of that. But we discussed that because I'll bring it in, like reversing the curve. So I'm still pulling the skin in from lateral, from the outside to the inside to prevent the dog ear from forming. So we very, very rarely ever see that. But it's not the end of the world if that occurs. And we treat these often from other practices that come in. Not a big deal. I never criticize those surgeons. These things sometimes happen. But if you
Yeah.
want to talk about the length of the incision, send me a photo. I'll draw it for you. It's that
Yeah, send
straightforward.
us your name and your phone number and just get the whole consultation already
And I
specifically
will
for
and
you.
I will draw it out for you.
And the last question, and I think it's
Okay.
very, very appropriate for
Okay.
this life, and is Marcel Noah. She's asking how long she needs to stop drinking. My surgery is January 15th, and Christmas and New Year's.
The
KKK.
surgery is January 15th.
Yes.
Oh, I think he's gonna have a great New Year's. That's not a problem at all. Like some surgeons would even say you could have a glass of wine the night before. That's not going to be a
Uh-huh.
problem. But if we're doing like New Year's type of drinking, like I would hold off like several days or a week before. But a glass of wine the night before, not a problem. You
Mhm.
know, three White Russians, maybe hold off. You know, and I would hold off on that. But yeah, you're good to go. If I'm seeing you middle of January, you're gonna have a great Christmas and a great New Year's. Don't even worry about it. All right.
Okay. Okay. Thank you, doctor. Thank you, everyone, for
Great
joining this
seeing you, Lily. Great
live.
seeing all
Great
of you,
seeing
and
you
I'll see you next time.
next
And
Thursday. Bye.
bye, guys.